Hello everyone, this is Dr. PriyanakaAgarwal here. Welcome to our channel Talking Tooth. So we are preparing pharmacokinetics for our university exam in this video. Okay, so we have already done absorption of drug with these questions in our part 1 video. Okay, so this video is part 2 and we are doing distribution of drugs being focused on plasma protein binding as an important question. Okay, now what do you mean by distribution of drug? So as you can see in this image, after we take the drug inside, like after we administer the drug, it get absorbed into the bloodstream. Okay, so we already know till here. Okay, now after absorption what happens, we will see now. So after absorption, when the drug is inside the blood, it should enter into the organs, right, for its action, isn't it? So this movement of drug from the blood into the tissues or the organs for its action is nothing but the distribution of the drug. Now, so after absorption, once the drug gain access to the bloodstream, it is distributed to other body tissues. Okay. Now this distribution, the extent and the pattern of distribution will depend on some factors. So there are 5 factors. First 3 are related to the drug inside the bloodstream. Next 2 factors are related to the organs. Okay, so let's see this. So when we have our drug inside the blood, we have plasma proteins in the blood. So drug will attach to these plasma proteins. So distribution depends on the extent of binding to these plasma proteins. Now for the drug to get distributed, it should cross the membranes, right? So this permeability to the membranes depends on the lipid solubility of the drug. So this lipid solubility again depends on the ionization of drug at the physiological pH. So we have already covered lipid solubility and ionization in detail in previous video. Okay, so we already know that now non-ionized drugs are lipid soluble and they can pass through the cell membranes. Ionized drugs, ionized molecules are water soluble and they cannot pass through this. Okay, so distribution will also depend on the lipid solubility and ionization of the drug. Clear till now? Okay, so now we are moving on to the next factor. So we have our tissues. So the extent of or the difference in blood flow to the tissues will also determine the extent of distribution. Okay, and after the drug is inside the tissues, how much the drug is binding to these tissue proteins. Okay, so extent of binding to tissue proteins also determine the extent of distribution. So I hope you are clear about the 5 factors. Okay, so among the 5, the first one is the previously asked question. Okay, so we will go in detail with the first factor. So that is plasma protein binding. So we are going to study this question in 4 points. Okay, so these are the 4 points we are going to study. Okay, so most drugs bind to plasma proteins in blood. So whatever drugs we have, most of them bind to plasma proteins. Acidic drug will bind to albumin. Basic drugs will bind to acid glycoproteins. So albumin and glycoproteins are nothing but the plasma proteins. Okay, so can we say that a particular class of drug, like can we say the benzodiazepines, which are nothing but the sleeping pills, right? So can we say the sleeping pills or the benzodiazepines bind this much to the plasma proteins? Can we make the generalizations like that? No. So extent of binding depends on individual drug. No generalization for pharmacological or chemical class can be made. Okay, so among the benzodiazepines, like the flurazepam will bind only 10%, alprazolam will bind only 70%, lorazepam will bind 90% and diazepam will bind 99%. So like this, the extent of binding depends on individual drug. Now the next question, what happens to plasma protein binding if we increase the concentration of the drug? Like for example, if we are taking like 100 milligram of drug, out of this 50 is getting attached to plasma proteins. So we can say 50% is the binding. So imagine if you increase the concentration to 200, and can we say the same amount of drug will bind? Can we say again the 100 milligram and 50% will bind? No. Why? Because we have limited amount of plasma proteins. So now instead of 50%, it may bind to 40% or 30% of the administered drug may bind. So when you increase the concentration of drugs, binding sites get saturated. Okay, So this will decrease the binding fraction of the drug. So out of 100%, now only 40 or 30% will bind. So this is about the first 3 points. Now coming to the clinical significance of plasma protein binding. So why the plasma protein binding is important for us? Okay, so we will learn the clinical significance in 3 points, 1, 2 and 3 points. Okay, so what happens when the drug is bound to plasma proteins? Okay, so why it is clinically significant? So understand that only the free drug is available for distribution. Whatever bound drug is there, it is restricted to vascular compartment. That means it is there in the blood only. Okay, it will not move out. So that's why you will have low volume of distribution. Okay, so you will have low volume of distribution. So because this bound drug is not available for action, metabolism and excretion. Why? Because it is there in the blood only. Okay, it is not moving out. Okay, so this plasma protein bound drugs will act as temporary storage of drug. Why temporary? Because whenever the free drug levels will fall, this drug will dissociate from the plasma protein. So whenever free drug levels fall in the plasma, bound drug is dissociated. Okay, and all of this will make the drug long acting. Okay, so slowly the drug is released from the blood, so which increase the duration of action of the drug. So this is about like what happens when the drug is bound to plasma protein. What is the importance of it? Okay, now imagine you have 2 drugs in the bloodstream. One drug is having high affinity, another drug is having low affinity. Now what happens? So high affinity drug will compete with low affinity drug for the same binding site. Okay, and will displace the low affinity drug. Okay, now because of this, what happens? There is increase in concentration of this low affinity drug, and that can lead to toxicity of this drug. So but this is temporary. Okay, good thing is this is temporary, because whatever free drug is there, it is getting distributed, right? So as free drug get distributed, metabolized and excreted. Okay, now imagine you have 2 drugs which have same affinity for plasma proteins. So 2 high affinity drugs will not displace each other. Okay, for example, you can see the probenecid and indomethacin. They are the drugs. They are having same or highly bound to albumin. Okay, but they do not displace each other. Now acidic drugs will not displace basic drugs and vice versa. Okay, so this is about when you have 2 drugs in the blood, how they affect the plasma protein binding. Now what is the effect of diseases on the plasma protein binding? Okay, so when you have hypoalbuminemia, like when the albumin concentration in the plasma is decreasing, obviously there will be decreased plasma protein binding of for example phenytoin and furosemide. Okay, uremia, which is increase in urea in the blood. Okay, so this will also decrease the plasma protein binding of phenytoin and pethidine. So in case of pregnancy and inflammatory diseases, there is increase in plasma protein binding of propranolol. Okay, so for example propranolol. So this is about plasma protein binding. This is about the distribution of drugs. In our next video, we will cover the metabolism of drug. Okay.